going to do this a little different today. This is Professor Shetty had this idea that, rather than us kind of just presenting at you, a couple of us are going to be hosts. And Professor Chunara is going to literally be our on-stage guest. And, we're not going to be like, I'm not going to play Oprah. I think I'm going to play Christiane Amanpour, and I'm going to ask Dr. Steinhubl if he will play Anderson Cooper. So part of what we're going to do this morning is after we've had a presentation, we're literally going to, be interviewers and ask questions. And, hopefully what this will do is just really open this up for you as well. And then after that, we're going to ask you to go into breakout sessions and have a discussion and then come back brimming with all these questions I know that you're going to have. And then we're going to have an open discussion. So let me introduce my host for today, my co-host in this session. And you've heard a little bit about him. Part of his background, I think, as you can see visually, is that, he works in a space where understanding these issues are critical, or else he could not be successful. So it's great to have him here. Again, what you're going to see today is interdisciplinariness at its best. His undergraduate training was actually in chemical engineering at Purdue. His graduate training was in physiology at Georgetown, and his medical degree is from St. Louis University in Missouri. And as Professor Shetty said, his specialty is cardiology and interventional cardiology. So what you're going to see is, because his work is on cutting edge, because he leads a research team that's really involved in the design, development, and management of clinical programs, which are built specifically around these kind of capabilities of a wide range of digital technologies, including things like wearable sensors, and he uses big data analytics. His team is really focused on reimagining of health and healthcare through the incorporation of these digital technologies. So I'm very happy to have him with us today, and thank you for being Anderson Cooper this morning.
I'll do my best.
Yeah, well, I'll do my Christiane Amanpour probably would kill me for trying to be her, but we're going to do our best imitations. Yeah. Let us, start with introducing Professor Rumi Chunara. She's going to put up a slide, and her slide's going to tell you her who, what, where, and those kinds of things. But I know what you really want to know is the essence of her accomplishments. So most of us probably in this session typically collaborate across disciplines. Well, what you're going to find out is she's an N of one. Her BA degree comes from Caltech, and it was in electrical engineering, and of course with honors. Her PhD work was at the Harvard MIT Division of Health Sciences and Technology. And it's a program that I highly admire, because I know a lot of the Microsoft people that have been there in some of their health work. That program really brings people together, the clinicians, scientists, and engineers, to translate research findings into this clinical practice. Their goal there is to improve human health. So her training is just perfect for today. Now, when we look at her work, the goals that she sets really reflect this interdisciplinary training, because what she's trying to do is to develop computational and statistical approaches for acquiring, integrating, and using data to improve population public health. So, hopefully you've had exposure to that. In her early work, she really was focused on improving knowledge of the kind of how and why of infections and diseases in populations, using SMS data to improve, for example, Ebola models. Now in her work, she really concentrates on the design and development of data mining, machine learning methods, and she's trying to address challenges related to modeling for risk prediction, as well as fairness and ethics, which she's going to talk to us about today. And the reason I'm giving you this long bio is so that you know the range of questions that you might ask her today. She has all kind of awards. As we know, she has an NSF Career Award, Facebook, Max Planck Sabbatical Award winner. But the thing to know today that you're in good hands, you know, most of us, when we look at Rate My Professor that talk about our teaching, we have these terrible complaints. But I thought she had this wonderful comment. Best professor ever. I've taken foundations of data science in my first semester and found it difficult. We used to pull an all-nighter to complete the assignments. There is no homework, but after the course, I knew data science more than people with an MS in data science. She is the best professor and her assignments are awesome. So knowing that about her, this is the best UCLA welcome that I can give her. So let me turn it over to her at this point in time.
Well, thank you. Thanks, Vicki, for that amazing introduction, and never thought anybody would quote that website. So there's definitely some, you know, a lot of learnings on there too for me. But thank you, Vivek, Steve, Vicki, everyone for having me in this great session. And actually, yeah, some friends attending the Institute and new friends, looking forward to interacting with all of you. Like Vicki said, that's a great setup for the session. And I don't know, great to be interviewed on the hot seat a little bit. I do have a set of slides that are about maybe about half an hour. So, and then of course, like she said, we'll have time for discussion, but I'm also happy if you want to, you know, put any, there's like 35 on here. So maybe you can put it in the chat, or like, I'll try and pay attention to the Zoom hand raising and all that. So yeah, feel free, I think in the moment too, if there's anything to clarify. Sounds great. Okay, let's see. So let me just try and do the share screen. And then, Vicki, how does that look? Good?
Perfect.
Okay, great. So yeah, so as Vicki mentioned, I have a bit of an interdisciplinary set of hats on. I'm jointly appointed in computer science in the engineering school, and also in biostats, sorry about that, in the School of Public Health. I think maybe if you can, everyone can just mute. I'm getting a little bit of feedback. It would be helpful. Thank you. And I also wanted to mention that I'm launching a new center at NYU this fall, really excited, the Center for Health Data Science. So we're specifically going to focus on those data science aspects related to health, both advancing scholarship, research, teaching, but also, and I love that the word ecosystems was already used, kind of because we're going to bring a lot of people to the same table, right? We know we all need to interact with different perspectives, different expertise, and we view that will advance the work that's being done. So a little bit of a platform for that interdisciplinary kind of even, perspective from different places. All right, and before I really deep dive, given these multiple hats that I have, this topic is very large. And so you'll see that I tried to bring together threads from the kind of the public health theory frameworks, as well as from the computer science side, more on the risk prediction and algorithmic fairness literature. But you'll see some of the examples also most focused, as Vicki mentioned, on that kind of risk prediction machine learning side. So I didn't use any specific examples from mHealth, but I think that's actually a great start, because I'd love to hear what folks are working on and bringing to that from those types of data and settings as well. Great. All right, so let's dive in. I started just with some background. This is, folks might be already aware, but let's just go through it as a little bit of motivation before we hit the ground on this topic. So this is from the WHO, the definition of health equity, and you can see that there, absence of unfair, avoidable or remediable differences in health amongst population groups. And so they define that socially, economically, demographically, or geographically. And then just to add to that, we often talk about this term health disparities. We know that term, and we can also consider that useful as the metric we use to measure our progress towards health equity. So that's highlighted through many multilateral bodies, WHO, CDC, etc. And now here, and you know, this people have seen these in different ways. I just wanted to highlight some of the where we stand on health equity, right? And looking at that by one of the metrics, which is life expectancy. And globally, unfortunately, we can see sharp disparities, and this also persists at multiple spatial levels. So we'll dive into that further. So you can see, for example, here at the peak, we have some countries with great life expectancy, like 85 years plus, like Hong Kong, Japan, Switzerland, you know, those are all around 85 years. On the other end of the spectrum, it's all the way down to only 53 or 54 years as the mean life expectancy in those countries. So that's a lot in Central Africa, Central African Republic, Chad, Lesotho. So, you know, it's as if we have people who have about a double life compared to some other people in the other parts of the world. Now, as I mentioned, that also persists at different spatial scales. So now we're looking at United States life expectancy by county. So we don't even have to go globally to see those sharp differences. We see that just across the most healthy and least healthy kind of counties on this map is similar to the difference between, on that previous map, the US and say Mali. So depending on where you live in the US, life expectancy can vary by more than 20 years, right? So that's surprisingly wide. And actually has widened in recent decades. So that's even more concerning. I'm based in New York City. So here we even looking at within one city, we still see, you know, gaps based on where you are in the city. You can see from different parts of Staten Island or the Bronx have much different within those areas, and then between Manhattan and those different places as well. So all of this is quite concerning. So I mentioned that, you know, not only is that spatially challenging, but we see that these gaps are widening. So this is data specifically within women, and this is data from the National Academies of Science, Engineering, and Medicine. So over a few decades, so from 1980 to 2010, and that trajectory has continued, we see that there's a widening gap in life expectancy for the group of the richest women versus the poorest, right? And so that's like over a 10-year gap as well. So that's concerning that this is increasing in recent years. Now, this is all very well studied in the health disparities literature. So that's not anything new to know. And the literature is vast and deep. So there is a lot of good literature there. And so I've just summarized a few points about health disparities and what they're related to, right? So here I've summarized from some of the literature about they're related to, health disparities are inequitable, directly related to historical and current unequal distribution of social, political, economic, environmental resources. And these can kind of play in at different stages. So development of an illness, there can be disparities in who is most at risk, for example, who can access healthcare, who can access good healthcare. There's also disparities in that. And then, of course, the outcomes of the healthcare that one engages in, and the different diseases that exist. Now, here's a little bit, another important as scientists, you know, and I pull this together across multiple different literatures. You can see this in the economics literature, public health literature, some of the sociology, that actually some types of interventions can actually widen inequalities. Okay, and this is this can be thought of as kind of an income effect. So one of the examples I gave here is smoking cessation campaigns. So let's look at that in a little bit closer detail. So from the 1950s until today, tobacco smoking in the US has actually decreased dramatically. So it's very good for the population. Though inequality in smoking rates has actually risen, right? So although it's positive that adult smoking rate has dropped from 47% in 1953 to 15% today, so that's a large drop, that's very good overall for a population. In 1953, smoking rates across all education levels were about the same, whereas now, if you're a graduate degree holder, fewer than 4% of those people smoke compared to adults who are only able to attain, only had the opportunity to attain a high school level education. 34% of them smoke. So you see how this is widening within certain groups. Now, people have looked at this from many different angles, and this considered in the economic literature as an income effect. So basically, because like a lot of the campaigns for and anti-smoking interventions were basically less effective for people with a lower education. So some of the media campaigns overall, yes, if you have the ability to engage in some of the interventions there, because you already are kind of comfortable in other ways, maybe have gotten more education, that was a little bit more easy for you to kind of see the reasons to quit and to also engage in those behaviors. Whereas for others, it's not as straightforward. And this is, this is difficult because, this is why a lot of the lower SES groups tend to typically carry the heaviest burden of disease. So what people kind of, have put forward around this is, potentially focusing interventions, specifically for that lower SES group as one example of a way to, to not widen gaps. Let's see. And then in general, just to summarize, so it's important because even if we decrease overall, for example, smoking prevalence, inequality at a societal level is actually harmful for the population, right? Because you have different burdens of disease, you have different, people have different capabilities, and this can augment things in other ways. So one way that we can actually maybe more think about this when we go towards developing our science or intervention is actually to think about these in a multi-level framework. So I really like this framework from the public health literature. It's the biosocial framework of health from Yuri Bronfenner back from 1977. So it's not a new one, and it's it basically centers the individual, the darkest blue here, in these concentric circles, which represent these multi-level factors that also are important for our health, to consider for our health, right? So of course we have the individual factors, our knowledge, attitude, skills, our own physical properties, genetics, etc. But like we know from much of the literature, like for example, what we eat can be influenced by who we hang around with, so our interpersonal networks are also important. The organizations, right, and social institutions that we exist within, that may be where we work or where we operate, our communities, and then of course public policies. So all of these factors, outside of us as individuals, also are important to consider. Okay, so that's a little bit of going down on the, public health literature, health disparities. Now I'm going to take us on another topic, and then we're going to bring them together. So a little bit of a heads up around a little bit of a turn switch here. So let's talk about this idea of algorithmic fairness. It's completely on topic because it comes in when we're thinking about, again, equity, when we talk about using a lot of data, algorithms, prediction, machine learning, etc. And this is a whole literature as well, a very, very deep, lot of different, very innovative approaches. I'm simply just summarizing kind of the concept here. And there's many different approaches that have been developed. There's causal methods, etc. Happy to talk more. That's some of the research my group does, but I thought, let me just put up this introduction slide. So the general idea for algorithmic fairness, it can be broadly construed in some ways, in some of the approaches, as like a group fairness, basically, right? So ensures some form of statistical parity, right, for members of different, and like usually applied to different protected groups, and that can be assigned by like legal definitions or otherwise. Here I gave like a toy example where we're looking at hair color, right? So say we are looking at some kind of prediction model, right, where our outcome, I just put the Y with the hat, like what we're estimating, is what we're estimating. And one of the properties that we might have in our, in our population, our members, is the hair color. So some folks have red hair color, some not red. And then what we're looking at for algorithmic fairness is how do those outcomes get assigned across those two groups, right? So some of the people with red hair, we might have a positive, our estimate is positive, plus or some minus. And then for the folks with non-red, we might also have some assigned positive or negative. And then the idea is, with like an algorithmic fairness constraint, is that you'd want to ensure that the difference between, the probability of signing some kind of outcome for, in this case, red hair versus non-red hair is either 0 or constrained to some bounds where, and I'm again talking about red hair, but then A equals 1 or A equals 0 could be other sensitive groups like maybe gender if you're, in a binary way or others. So just pausing there, that's a whole literature. I just kind of did a very simple summary of some of it just to make sure everyone's on the same page there. Okay. Now, of course, there's a lot of work in this space. It's always growing. People are looking at concepts like intersectionality, using algorithmic fairness, etc. So by no means is that just the end all. But I wanted to now start to merge a little bit these topics and just say, just comment a little bit on, what we might think about looking at, both of these topics, and then I'll talk through some examples. Okay, so this is actually I can put the reference here. There's actually a review or perspective paper some of my students and I wrote from public health, computer science, and across in Nature Machine Intelligence. I can share that if anyone's interested, just to kind of again do this topic a little bit more justice and elaborate on it. But we talked about some of the challenges if we just look at the algorithmic fairness point of view, even for risk prediction models. And I'm just going to highlight a couple of those here, knowing now what we do about the health disparities topic. So these are just abstract illustrations of some variables and how they relate to each other in this kind of graphical format. And let's look at the left-hand side first, and just the nodes, the circles that are in white. So this is, some folks have seen directed acyclic graphs or Bayesian networks. You might see these kind of graphs regularly. If you haven't, that's no problem. Basically, just to summarize for you, the variables are the ones in the circles, and I'll explain what the letters stand for. And then the arrows show there's some kind of effect. They're known maybe through the epi literature or whatnot that we're picturing here. So on the left-hand side, we might have some health outcome H, so it's very abstract. And we might be considering both some covariates, some clinical variables, maybe C, that we know are predictive of that health outcome or related to it. And then we have maybe some perceived protected attribute P, right? Maybe we could say it's a race variable, right? Like if someone's Asian, white, Black, if they, identify that way. But we also know, just to add to that, that, race is kind of socially constructed, right? And so we have factors really that might, people might, perceive race based on these things, right? Maybe education, income level, what neighborhood. Those are the shaded kind of unaccounted for factors. And so the point of just illustrating this here is that even if we, account for this protected attribute, if we don't think about these these unmeasured attributes, right, we still could have variance in our outcome related to those. Okay, so just like a, one, challenge of just thinking about it in the kind of just simple variable way. Okay, on the right-hand side would be a similar challenge where, again, now we've kind of gone through the diagram. So we have some health outcome H, right? And then I have maybe a treatment T that is being applied that we want to observe what the outcome looks like. Again, we have some clinical attributes and, some perceived protected attribute. But maybe we're only considering a population that's insured, right? So if we don't consider the insurance status, which might affect selection for treatment, it might affect the health outcome also, then again, we're going to be our results are going to be limited to only that population. So just showing a couple examples if we think about fairness only within our data set and how there might be other unmeasured things we might also want to consider. Okay, so let's talk a little bit. I'll go into a little deeper on a few other studies that we've done to just kind of show that I guess would highlight the complexities around some of these topics and hopefully get you good seeds to provide some thinking for everyone. So the first topic, the first example is about risk prediction models in a clinical sense, and the challenge of applying those models to different places or different populations. And this was really stemmed by a lot of recent news. Actually, you can see these are from 2020, where it was found that looking at the literature in one case, and also in the news article, and cohorts in US-based, deep learning algorithm papers, and how those were disproportionately built with data from, and this says just 3 states, you can maybe guess where those are: California, New York, Massachusetts. And so given that these are kind of built from one place, and we're thinking, okay, how, if we're trying to, enable different places to leverage artificial intelligence, prediction models, what happens when we start to, use those models in different places? So what we did was actually use a publicly available aggregate data set of electronic health records from 179 hospitals across the, in this case, it's the United States. So they have, over 70,000 hospitalizations included from 2014 and 15. And so these are ICU data, and we focused on risk prediction for mortality in ICUs, which is a common risk prediction task. Okay, so we use some different metrics. I don't need to go into the details here. If you're interested, you can check out the paper to look at the model performance and how that differed. We looked at it between pairs of hospitals. So if I train the model in one hospital and try and test on another, or even if I take all of my training data from one region, right, and try and test on another region, or if I take all the data from maybe similar types of hospitals, like, they're all teaching hospitals. So we looked at these different axes just to look at, the kind of goal here was to see what's the generalizability in this real life data set, right? Okay. There's a lot of graphs here, so I won't, let me walk you through it. So in this case, we're looking at those generalizability across those different axes. And then first of all, on this slide are just between pairs of hospitals. So kind of on each of these plots, we have these different hospitals by row and column. And so you can see in the coloring just how well, like how much, basically in overall aesthetic way to look at it is like how well does it generalize by different metrics like AUC performance, calibration, disparity in the false negative rate, etc. And I'll just summarize that all 6 metrics that we use show large variability when transferring across pairs of hospitals. Okay. And then I'll also just summarize again across some of those other axes that I mentioned. Across hospital and region pairs, there were significant feature distribution shifts, right? So just using statistical tests to look at all the variables. One thing I'd add is this was kind of actually more enlightening, is we looked at, we generated a causal graph of also, we have all the covariates for the mortality risk prediction model. We used an algorithm that basically starts off with like all the variables connected and then prunes off the variables that are conditionally more unrelated. And so it leaves you with a little bit more understanding of the directionality of which things are related to which variables. It's a common off-the-shelf kind of algorithm. So we use that to see what's actually happening within these algorithms, like what's related to what and what's actually shifting around. And this plot here shows you where there were significant differences in the different variables all the covariates we're using for the prediction across those different axes, like I mentioned, like regional pairs or different, just even different hospitals, or the teaching status, or how big the hospital was, just to look and see, were there any places where maybe the data is just generally more similar. Maybe that can allow for us pooling the algorithms, the data better or whatnot. But overall, and you can see the red is where everything was significantly different. There were just significant differences across all the kind of clinical variable categories, vitals, labs, and others. And once we use that causal graph algorithm I mentioned to kind of look what was happening, actually a lot of the differences were mediated by race, which is a conclusion that could be multiple reasons for. So one, of course, the different hospitals had different distributions of populations in them, and those folks might have just different health outcomes, different tests happening. It also could be in the clinical ordering patterns were different as well, right? So we don't know the reason, but this also just indicated to us that not only do we have to look at how these algorithms are performing in different places, but we really should have some good provenance around how our data is generated, and so we can understand better where those differences come from, right? So that can help us know where to intervene. So I guess one conclusion I can summarize for you here is that it is very important to understand how the data is being generated in terms of like, is the in mHealth studies, we definitely look at individuals are generating data. Why would someone be likely to take a measurement or not take a measurement? And these kind of reasons are important to catalog also, because they can actually have impact differences in any kind of more further data analytic methods used. Okay, so that's kind of a little bit, I put a summary slide here just to highlight that, an understanding of that process is important, besides kind of ensuring specific parity or algorithmic fairness on algorithms. And, that can help you identify where those differences are coming in from as well. And that's just an abstract graph to highlight that. All right, so let me move now to a second example. This is less of an analysis and more about a review that we did, just to talk a little bit about, looking forward. How do we do that? I talked a lot about, okay, we need to better catalog data. We maybe need to think about outcomes in a equitable way. But how do we do that, given we know we have all these, multi-level factors that relate to health? Because we know, and this is all from the news and all that in popular press recently, so all of you are probably have heard about these things, but we've seen that, in algorithms, there can be biases, so all the way from imaging data. So we had a nice study here by Joy and Timnit from several years ago now on looking at in production, actually like in use, facial recognition algorithms, and how they performed worse, specifically for women with darker skin, right? And that actually was a very seminal study. It nudged along not only further research, but also, all these companies actually did update their algorithms, in this case by using more representative data for training. But we've also seen this in natural language processing. So when we take like word embeddings, I think everyone might have, even when they're sending a text message or email, you might get like a autofill, like what the next word might be. And so if you want to better predict that, people often look at like how words are represented in the space of different words. And people have seen biases in that, meaning, a word like man might be more associated with doctor, but woman might be more associated with nurse, right? Just based again on the repositories of data used for training these things. And then also, besides data challenges, also what outcomes are optimized for. And this also very popularized study or made famous study on racial bias in an algorithm for basically an algorithm used to pick who would be put into a further care management program to get a little bit more care, to improve their health. And because of the metric used, which was actually cost of the different factors people had, instead of what actually sicknesses they had, then they found that for the same level of illness, people who are white were more likely to be allowed, to be given this opportunity in this program. So that also is, the study happened, it was good because as the authors have discussed very publicly, everyone's been very receptive to kind of updating those things. So it's important to do that. But not only in these more modern heavy data analytic algorithms, we also see current CVD prediction, cardiovascular disease prediction, does encode some bias. So, for folks my age and anyone older, you'll usually, your physician will screen you for cardiovascular disease, where they'll look at your different risk factors, and if you're at likelihood for any kind of cardiovascular event, heart disease, stroke, etc. And these often take into account like all the factors you would think, which are important. Smoking is one of them, but also like your age, gender, etc. But this nice paper from Steve Yandowski and colleagues showed in 2018 that those current models actually had more error, right, in terms of what was expected via these prediction methods and actually happening. And let's look at the white bars. That's the one they were looking at, specifically for Black women and Black men compared to white women and white men. And the blue bars are some of the work they've done in that paper to kind of address that. That's good, and there's a lot of ongoing work in that space, but the white bars, you can see what they were highlighting. And so this is important when we think about cardiovascular disease, and let me look at this health outcome specifically because of the changing incidence and rates, right? So of course, we all know the importance of infectious diseases, COVID, we're just going through that. But also we have this large non-communicable disease burden in many parts of the world and growing in many parts of the world, right? So earlier in the 60s, 70s, we had really good medical interventions like pharmacological statins. We had good process for stenting. And so cardiovascular disease outcomes actually got a lot better, specifically in the United States, because people were able to get care, acute care quicker if they had an event, or a lot of preventative measures were available. But actually that improvement has actually been slowing down, plateauing, and even getting worse. So meaning cardiovascular disease rates are actually increasing in certain populations in recent years. And actually, who is that happening for? Actually, a lot of, again, vulnerable populations, non-white in the US, and in globally, a lot of populations as well. So why is that? That's, you know, we all can actually intuitively understand our lifestyles changed, processed foods are more available. And so this has become a big challenge, right? And there's been, again, a lot of work looking at that from the social epidemiology side to see what are those factors that now are affecting specifically, in this case, cardiovascular disease. And of course, some of them are proximal, some of them are distal, but you can kind of just see a summary of those on the right-hand side. So we considered this, and I'll just highlight a couple, you know, kind of ways we're looking at this in our group, which is one, and is to think about algorithmic fairness. First of all, in light of the fact that CVD prediction, you know, you know, the error on those is disparate. To elevate kind of these fairness metrics, not just to consider like fairness at the individual level, but also at this, you know, multi-level perspective. And so I won't go through the right-hand side. It's a little bit complex graph with a lot of colors, but basically the idea is that instead of just taking into account the individual level factors, we're now adding in these multi-level factors. So that's one, you know, just one perspective and direction. We have also looked at, you know, we looked at, you know, as a group that works on kind of more modern analytic, not modern, but, you know, more advancing statistical methods through like machine learning. We have looked at risk prediction models for cardiovascular disease, and are people including these multi-level factors? And we wanted to do a review to see how that's happening, and maybe, you know, extract some best practices or some gaps about where there might need attention. So these graphs on the right-hand side just summarize some of the findings from that review that was published in AJPH last year. And so first of all, let's say on the, you know, top left, we first of all looked at where a lot of the studies were happening, which is where the cohorts are that people are looking at. So of course, a lot of those based in the US, a lot of good research, you know, a lot of world research knowledge ecosystem gets derived through the US. And Europe, a lot from China, but really a lot of the places where we're seeing some of these disease burdens really increase, there's not, you know, research happening there, or like, you know, folks are not getting, you know, able to get involved in those studies to participate. On the second plot B on the top right, just seeing the types of, yeah, we're all thinking about multidisciplinary research, you know, what kind of fields are being involved. As a, you know, if I'm doing risk prediction, I would want the expertise, you know, from machine learning. I'd also want the expertise from medicine, clinical medicine. So it's good to have the balance of those. The bottom left, we just looked at what outcomes, that's I won't go into too much there. On the bottom right, we looked at which social determinants people are looking at and including. And of course, these are things are, you know, you can see it's strongly, you know, people are thinking about gender, race, ethnicity, less so about things like maybe where someone lives, you know, what's available in that place. Of course, that makes sense because those things are harder to capture, right? And if we have electronic medical records, there's, you know, people are working on standardized social determinant checklists, but they aren't available everywhere. So those things are harder. But as those things become more available, we should be considering, you know, looking at that if we're looking at risk prediction. All right, so my final, just like little blurb to talk about is now the data science community. A little bit I alluded to it when I talked about where a lot of the studies were happening in this broad idea of, you know, algorithmic fairness and public health disparities. We know that we need to bring a lot of people, a lot of different people views to the table, right? From a discipline point of view, but also maybe, you know, place point of view, we could have some studies in different places where they're needed. So just one, you know, very exciting project, a project I'm very excited about. So I wanted to share it with you all. We know that a lack of diversity, not just it's nice, but it actually leads to poor outcomes in many fields of endeavor. This has been studied. I just put a sample of the publications here at the bottom. both in healthcare, like business management, scientific discovery, economic profit, and machine learning. And so we know we need the same in, when we're thinking about data science, machine learning here as well. Here I put up a graph of where data science jobs are available on LinkedIn. Of course, that's one sample, one platform that's used, by certain places more than others. So that's going to skew what we're looking at. But you can see in some places they're just actually, not any kind of opportunities available. And so we have a new NIH training program with our colleagues. Specifically, this is in one of the places in the world where we're, seeing a lot of these increases. This is with our colleagues at Moi University in Western Kenya. They have a strong history of, trainings, biostatistical training, a lot of good collaborations and partnerships through AMPATH, through Brown University with my colleague, Dr. Joe Hogan, and Dr. Vedantan at NYU Medical. And so we've come together to look at the data science project here now. Can we advance their training in that realm also? So we'll work on building that program at Moi. We'll have some folks from Moi come over to NYU to not only take some of those advanced, we have great machine learning, artificial intelligence courses at NYU. We envision they'll also add to our, wonderful School of Global Public Health to infuse some of their research expertise, and we'll build some partnerships that way as well. And just a little bit notes why we're focusing the program on data science for social determinants. One, well, we know there's all these multi-level factors, but often, like I mentioned, they're not available in standardized, easy to grab ways to use data. So we have to take a look at some methods to capture that data, maybe from unstructured sources. So we need to think creatively there. And also because these all apply across the whole spectrum of disease and the pathways are much more complex, right? They're more distal from your outcomes. So you need to have more flexible models. And so that's another reason we're looking at, leveraging data science and machine learning flexibility on that topic. And thanking some, my students who have done some of the great work you saw in this presentation, and funders, and really looking forward to hearing from everybody what you're all working on and any thoughts and questions. So looking forward to it. Thank you.
Thank you very much. That's a lot packed in to a short amount of time. So I have to thank you for, many of the issues you raised are really complex. So I think unpacking that in the time we have will actually be great. I'm going to start with a question that is kind of close to your last slide, and it really gets into this notion about social determinants of health, because a lot of the work that we do, we're looking at a slice, and that's part of what you were talking about. So can you talk a little bit more about how AI can right the wrongs in terms of, directing science and our intervention, when health disparities are not just about differences, but they're really about social risk or social vulnerability. And that's more in our systems. It's, you often hear people talking about structural racism. So can you unpack that a little and talk a little bit about that? Because I'm sure our scholars struggle with, how to bring in these social determinants, but not in a piecemeal way.
Yeah, that's a great question, Vicki, also bringing up a lot of important topics. So let me try and speak to it. So as you kind of working backwards, you also talked about looking at social determinants more. Can we do it more comprehensively instead of limiting our view? That's one thing, as you mentioned, and then and also just in general, this idea of using AI, as you started off with, in terms of looking at this problem. So, right, yeah. So actually, you're exactly, it's a challenge. It's not, there's no easy solution, I would say, to the last part. When we looked at the review, for example, on cardiovascular disease and social determinants, if studies included some social determinants, usually a limited number, it's not across the whole spectrum. We know health is a complex combination of factors. At the same time, I would say, yes, but in systematic study, we know also we can kind of narrow what our goal is. If we're interested in prediction, within a certain time period, maybe some of the longer term effects are less, going to be relevant for that problem. So just to be more tangible, we are looking at developing, risk prediction models that incorporate multi-level factors. And some of them there isn't that much of importance in the prediction just because they really impact things over a longer time. And so if our goal is like a narrow time window prediction, it might not be as relevant. So, just systematically looking at things might help us focus a little bit more, but still with that context. I think it depends on what our question is. And at the same time, I'll also mention that data is, any kind of analytics is not separate from the data available. So those things are also becoming more available, structured. There's good initiatives that way that might enable us to, like I mentioned, the social determinant checklists that are being integrated into many electronic medical records, et cetera. So it's, that's a process, but at least that can also help us address your question here. Regarding the first part, yes, and I think that sometimes, we're all human. And so sometimes, we might make mistakes, and that might be one way. Obviously, many who work with machine learning might know that's a good way can eliminate some irregularities or errors as well. So that might be one way that it might come in to be useful on one side, or at least measure those so we can address them however appropriate. So some broad strokes there. Yeah, but happy to hear if you have any other thoughts.
Any other comments on that? Okay. Steve, you want to ask a question?
Yeah. I've been trying to think of a way to formulate this question. I mean, first, I loved your talk. That was, it made my head hurt in a good way of just thinking of the challenges. So that was really wonderful. So thank you. But I want to ask a question in a way that doesn't bias you with my underlying bias with it anyway. So because I'm a clinician and I'm an old clinician, I've lived through the when I started, it was handwritten medical records and big issues with that, right? So we have electronic health records, which have now are dominant, which there's some very good things, and it's a huge source of data. So to try to be unbiased, tell me what you think of the electronic health record as a source of a lot of the machine learning work that's going on right now.
Yeah, that's a great question, Steve. And I think your perspective is you probably have good perspective on that. So right. So a lot of times we all know in healthcare, we're using data that's generated for certain purposes, right? And we might be repurposing that. And so, I work with electronic medical healthcare, health records, claims data, also, different social media data, all generated for different purposes. And that's dynamic also. So it's not good. So there's going to be a lot of issues. But I would say in terms of in data in general, let me make a broader statement. Data in general, it's very important, right? We need to have quantifiable metrics. We need to have measures which we can look at. How do we improve? How do we know where we've been, right? It's good to have things to quantify. It's not the entire picture also, right? So it may be generated just from a certain population, maybe a certain way. There's always, another piece to it that is important. And so if health records are capturing something that a doctor quickly could write down to make sure that, if the record is there for their patient, it doesn't exactly capture the full conversation they had, the full interaction. We need to be cognizant of that. And there's certain, tendencies that can make the data also biased in certain ways. And so that's going to be the case. And I don't think there's any perfect data set. I think we're always going to have to look at it in a fuller context as well. Does that get at what you're asking about, Steve? Yeah. Yeah,
and it's a well nuanced answer. I think that is it. And now I'll share maybe my bias, which is possibly more obvious than I would like it to be, but because electronic health records are designed primarily for billing purposes, right, to improve our healthcare systems to bill at a higher level, and because I don't know of any healthcare provider who looks forward to accurately documenting everything in the health record they'd like to. Most studies will show that providers will spend an hour or two at the end of their workday at home, finishing their electronic health record. So it's essentially we focus a lot of our research on electronic health records, and there are gems in there, that is valuable things. Some of the very first research I did involved spending a lot of time going through paper medical records and blowing the dust off and trying to abstract what information I was looking for. But when I think of all of the the information that's missing, the information that we did a study several years ago where we looked at the diagnostic accuracy of something important, like it was deep vein thrombosis and pulmonary embolism, right? And find that when I or a colleague will order an ultrasound of the leg because the leg's swollen, it is associated with the diagnosis of potential deep vein thrombosis. So now this individual has this diagnosis in their chart, and even if the ultrasound is negative, and often it is, that diagnosis stays there. So there's a lot of, but because of the purpose of the electronic health record, we end up with a lot of false information. We end up with a lot of incomplete information. And then on top of that, you end up with a lot of the inherent biases that are, with every interaction that individual has with the health system, plus, the differences in the health system. So, when you were presenting some of your, I think in a very busy ER, very busy ICU, they're not often going to have time to document, let's say, all of the comorbidities, all of the medications that came in. Whereas in a better staffed setting, and where they have other people other than the primary care team who can do that, it's a much deeper record. So anyway, now that I'm saying this all out loud, it's sounding much more like an editorial perspective than it ends up being a question. But I guess to me, I feel like for many reasons, it would be great to be able to fix that in a way that does support, really, if you think about it, of making electronic health records as a way to keep people healthy, everybody healthy. That if we were going to redesign it off the bones of what we have now, we could really do some amazing things. But I worry about, because if it always stays as a way to just bill at a higher level, that we're going to always have a very hard time using this very rich data source as an unbiased resource of information for model building and algorithm development.
Yeah, I think those examples, they were helpful, Steve. I'm glad you cited those specific examples to make it very tangible. And you're right, it leads me to hope that, if that perspective was in there in the design also, that there's many possibilities.
Yeah, well, anyway, sorry about just going off to, because I think there are so many gems in there, but then in the electronic health records, it can be really helpful, that can make a big difference. And I'm very happy to hear that there are some electronic health records that are picking up the social determinants of health and other drivers of health that are so important. Unfortunately, I haven't seen that yet, so I suspect it's slow, and I worry that because systems aren't paid to enter that information, that it's going to be very siloed at very successful academic medical centers that are able to do something like that.
Professor Shetty?
I'm curious. See, the typical mHealth researcher has to reconcile siloed mHealth data from variables with EMR data, with public registries, and they all exist. They're not interoperable. They all exist within silos that HIPAA makes it impossible to navigate. And with the best of intentions, the mHealth researcher has very limited resources. Your thoughts, any solutions? How do you approach that?
Yeah, those are very, persistent challenges, Vivek. I think let's see. So, but addressing this, issue of siloed, data, basically data, if I can unpack it a little bit more, the data is available, owned by different entities, maybe formatted differently. There's kind of these multiple levels of challenges. On the one hand, ideally, of course, this is difficult because of, the nature of, academic enterprise or whatnot. Ideally, we would have some collaborations that are a little bit long-standing so that people can feel comfortable, even if it's a new study or even if it's, just a pilot work, to be able, someone to reach out to kind of more easily, or there's a established, maybe agreement or, way to access things. That would be the ideal case. And we've benefited in some ways where we have a longer standing partnership, and then for a quick ask becomes less burdensome or difficult. So that's maybe just a broad comment. But more specifically, then also that speaks to the value of people, right? And so meaning, team members who have different strengths also can be helpful to share, maybe if, the data is seemingly difficult to link, in a case, then you might have someone who knows, who is more familiar with that aspect of things and could come up with an idea. Some of our good work has come from, multiple perspectives coming together and from those different methods. So I think I agree, it's persistent challenges, no golden egg solution here, but definitely the value of people and has been very important for us for getting, to that point where we have something we can better sit down and analyze that makes sense.
I'm going to follow up on Steve's question about the electronic health record, because this is something we're working on and something the federal government's really interested in right now. One of the things in the EHR is the language that we use and what happens in terms of quality of data. And so the question about what AI may be able to do to fix this. So for example, we're all pushing for race to be better. So we're going to find that we're going to change our definitions. The OMB one is pretty outdated. So we're probably going to try and do subpopulations in terms of race. Right now, one of the things the federal government is dealing with is sexual orientation and gender identity. And if we look at the definition of transgendered, you would see that over time it changes. So what we're trying to figure out is if there are methods in which AI can be trained to be more sensitive to the changes over time, so that what we have in electronic health record, we can continue to use. But it's like people come in and, even our racial designations, people are starting to use different terms. That's not what they used 3 years ago. So you either have to have the cost of a coder that is doing this, which that's not going to happen, or we figure out if AI can help us. Do you have any comments that you can make on some of the techniques or approaches that will keep the quality of the data consistent?
Yeah, I think that's a really good question, Vicki, and yeah, a good it might be an important problem to investigate. And let's say, so just to abstract the problem a little bit more, we're looking at changing maybe definitions, maybe semantics, maybe one could say categorization of things over time, right? And being able to then in a reproducible way look back and maybe reconcile all those things that are similar or not. And yeah, we can definitely look at that from a methodological perspective. And even with unknown, like if we say maybe in the future this might change in an unknown way, can we keep tabs on that? I'm just thinking of some other examples, like from the infectious disease space or even the recreational drug space. Researchers have used text data, and the former from like news information, latter from maybe social media, to learn about new maybe infections or new, also in recreational drugs. A lot of young people, I have no idea about this, but apparently they have all these new drugs and terms and things like, I never heard of these terms, and then somehow that's like a new thing and it could be important, right? So people have looked at those methodology. If folks are interested, that's some set of literature to look at in terms of like, one could say I guess like new term definitions or not anomalies, but like detecting changes and how the same thing is referenced. One could imagine looking at things like that in order to, in an automated way, organize it and allow for that, right? So that's an interesting problem you've posed.
I guess the question is the extent to which people maintaining the EHR see it as the responsibility to do this, because it does require an investment. So can you kind of talk a little more about the fairness and the social justice aspect of this work?
Yeah, that's exactly, you've posed it. Like I say some people, there's actually a slide I'd like to use. I didn't include it today about like where you can have inequities come into the whole data science pipeline, right? So of course we talked about training data, the differences that we had that gender shades example, where there could be different representation. You could have what is optimized for in the algorithm, the case from that science paper. But even what questions are posed, I think actually there's a level of fairness or unfairness that can be there, right? Like if no one asked, like, why don't we account for social determinants in risk prediction, then, no one would do it. So, I think a level of like who's involved also who's at the table is a justice issue, because that will impact all of these things, going forward. And so that's I think that's where I would look. Of course, we all have responsibility, and it's all, we should all be aware of these things and get educated. But I think it's always valuable. And in fact, it's not just nice, it's actually, it can augment our work to have, different perspectives. So to your point that, if that question should be one we consider, yeah, who's there, like, advocating for it is important.
Steve, you have a question?
I was just going to build on that, because I think one of the who owns that information, how, and this is, I'm a big proponent of the idea of a personal health record, right? So we kind of accept as a fact that our electronic health record, that in some way, whether through tax money, through our employer, through our own funding, we are paying for it. And it's very personal information, yet we've kind of accepted that it's not ours, that it's, for me, it's Scripps Health it owns that. We get little bits and pieces, and with my chart and some with open notes, but those records aren't designed for us. And again, everybody's going to have a different idea of how closely they want to look at that. But I think one of the keys owners of that information that need to be involved, Vicki, to build on, you said it has to be that the owner of that the information, or the patient themselves. And I think that also has a lot of impacts on a lot of things, the commercialization of healthcare, where people can pick and choose, okay, I want to go here to get this and do this. If they have their electronic health record, or they have their own personal health record, they can do that. If somebody wants to connect wearable data with it, that's also should be theirs, as opposed to most of the consumer companies who have now, they're able to connect that with it too. And I'd like to see us moving in that direction. Do I realistically think that's going to happen? Not anytime soon, but I think that's a way to, allow the owner of allow the person to own their own data, and allow them to contribute to keeping it up to date and keeping it accurate.
I see a hand up, and just in case I murder your name, Arjun.
Yeah, hi. I think the landscape of where the AI methodologies are, getting affected by bias is also it's affected by simple things like how we are now reporting gender and sex in a lot of our studies, and especially when people decide to change their sexual orientation, and which is happening quite a lot, and it's happening more so in the younger population than in the adults these days. And there's a lot of ethical question in terms of how does this affect a lot of our consenting mechanisms, right? Because we don't necessarily understand and respond to the what's in it for me question when they go through these changes, and then assuming that we reconsent them and we have them back in the studies and their data is still valid, we still don't know what's the trigger mechanism to retrain our models. And even if we did use existing models, at least from my perspective, it is so hard for us to embed a conditions apply on the implication of predictions to the average provider. So I feel like that's it's an ethical quagmire, and I feel like we don't even understand what those changes in landscapes are. And I feel like this is an open research area maybe all of us should come together and brainstorm on, because this is a nightmare. You can have a kid, like, we saw recently where the orientation was one thing 2 weeks ago, and then 6 months later into the study, it was, hey, I've been thinking about it. I have come out and, declared myself to be different now. And so can you now tell me what's in it for me to be part of your study? We didn't have, it was not an easy situation for us too. So I just wanted to put it out there, because these also have legal implications depending on the state lines. And yeah, I just wanted to share that, frustration from what we see in our practice.
Rumi, you want to comment, or I can?
I don't mind saying something. Thanks, Vicki, and then over to you. Yeah, Arjun, thanks for sharing that. I don't work a lot with pediatric, younger kids or young adults, or and I'm sure that's a specific topic, and can hear that can be very challenging from the research and logistical side. And I just wanted to make one. It's definitely not easy to address, but a comment also that was related to what Steve was just talking about personal health records and allowing people to have that agency. Just that, now, I guess best practices for a lot of research studies or endeavors is really to have a community group also, meaning maybe it takes a form through a community advisory board or community, some mechanism to allow to have the participants to have some, feedback or input into their own challenges. And, it links to, the previous conversation around who's at the table. And it's also, besides us as the researchers or practitioners, those folks too, that should be at the table. Maybe they can share what they would want most in that case, right? If they agree it's not, then maybe, I was going to say if it's not in it for them, but if they agree what they want to get out of their participation is not achieved, they should have some mechanism to satisfactorily disengage from all sides. So just one comment around this kind of engagement of community.
Yeah, I'll also comment just a little bit on that, because I happen to be co-chairing a federal advisory committee where we're looking at the collection of data on social determinants of health and SOGI. And in particular, when you start thinking about sexual orientation and gender identity, it's exactly what Arjun is saying. And that was kind of what I was talking a little bit about, is in the course of a year, you could get, an individual coming in and changing. And so data quality for us as researchers, data quality then gets impacted by our inability to really have that flexibility in how we code that data that's in, there. And remember, with the 21st Century Cures Act, what happened is that individuals are allowed to have access to their data, to download that data. So what it means for a kid is their parents can do that. We're trying to get them to tell us what their, sexual orientation or gender identity is. But if the caregiver, doesn't have full access to it because they put it behind a firewall in order to protect the confidentiality, because there are instances in which you can do that, then sometimes caregiver doesn't even know. There's a lot of really interesting research issues here So Arjun, it just hit it on the nail of the things to think about. And it's kind of like, we have to be careful of what we conclude if we're not clear that the quality of what we're getting and the accuracy of it is there. And we also have to be, careful in terms of for the provider that they have access. I mean, we do this for those of you who work in the area of substance abuse. There's kind of a firewall about, the CFR 42 data. It's behind usually a firewall to some extent. So clinicians also have to be able to use it, and they want to use it. So Arjun, I feel for you because I know exactly what it is that you're struggling with, but I'm hoping that, within the next 6 months, we'll be able to bring some, some kind of sets of recommendation and standardization in the collection of the data and its availability. Steve, do you have another question before we think about going to breakout rooms? You're on mute.
Thank you about that. Sorry. So I loved at the end where you mentioned representation, and I think that's a huge unmet need. So I have this very unique thing where I work within the Alaska Native community, and we desperately need greater representation in healthcare as healthcare providers, within research and data science, and I completely understand why it's very difficult to do it, but I wonder how we get there and move that. And if it's something that just takes several generations, which I hope is not true, of just because for a lot of the Alaska Natives, just like a lot of historically underserved and the populations, they have a lot of reasons to mistrust healthcare providers, healthcare researchers in particular. And are there ways that we can do that because I think to me, that's one of the biggest, most important ways where we can accelerate greater equity in both care and in research. So I'm curious for both Vicki and Rumi, if you think if there are other things we can and should be doing beyond what the programs NIH and others are supporting.
I'll let Vicki go ahead. I'd love to hear your thoughts first. Yeah.
Oh, okay. One of the things, and NIH does focus on this, and this is, the value of what Vivek does in this workshop, is that we really have to focus on the scientific diversity, the scientific diversity in the workforce. And that's in terms of science, that's in terms of representation. Part of what, and I think, Steve, you probably have a lot of experience with this, is that it's the assumption of who we bring to the table. There are ways in which, in terms of the coding of data, there are ways in which, when we think about data science, there are many places that people can participate in data science that is actually a contribution, but we tend to think of it all as at this level of the PhDs, PhD, MDs kind of thing. But we're really trying, at least, in my center and some other places, is to develop what we call these data warriors. And it really is kind of these data science warriors start with kids that can do coding, kids that can come to the table and call out, what's missing. So for me, part of it is the representation is realizing the value of where community voices can be a part of it. It may not be in, the way we scientifically think about it, but it has to be in the way in which representation impacts science. See, we let science lead and say you have to have a particular degree. We're trying to do this thing where we say it's the representation that should be leading the science. Rumi,
I
any
don't,
comments?
no, that I'll let it stand there because it's great. It was great. Yes,
Yeah, I
thank you.
love that. Thanks.
Well, I think at this point, what we should do is to actually let you move to breakout rooms. And I'm going to give you an assignment in the breakout rooms. And that is, if you can really raise up these issues of social justice and fairness, to really think about, because I think for many of you, as you plan your study, knowing ahead of time the kinds of things to think about might be great. So if you could talk about that relative to the projects that you're doing and come back with some questions or some issues. Those issues can range from a theoretical question to actual questions about how to do this in the context of the work that you're doing. So any questions about what you're going to do in your breakout room? Okay. Vivek, how long can we have them in the breakout room? 10, 15 minutes? You're on mute.
Probably about 10 minutes. I think it'll be a good chance for them to look at issues that may relate to their own capstone projects and come back.
I think we're back. Are numbers looking right?
Mm-hmm.
In terms of people being back? I think so. Okay. So I think what we want to do at this point, because again, this is, we aim to help you in terms of your capstone projects, is to open it up for discussions by you in terms of questions, either in terms of issues or things that are specific to the particular projects that you're working on. So let's use the raise hand function, and don't be insulted at all if you get muted because, when you're not talking, so that we can make sure that we have not a whole lot of audio disturbance. Okay, who wants to start? Really? Shyness is not something I'm used to in the mHealth group. That's unusual.
I think we have one question from Temi. Hey, Temi.
Go ahead.
Hi, everyone. Thank you so much, Rumi, for the wonderful presentation. Thank you, Vicki and Steve, and really everyone. This has been really good. One question I have, which stems from Steve's comments on EHR, that was a lot of learning for me in terms of EHR and some bias that could be in EHR. And I liked the idea of a personal health record, as you mentioned, where people own their data. However, I guess just the question of, so for example, if someone uses a wearable of some sort, they can integrate their own data with their EHR data. As we think about, or as I thought about that approach, I guess one thing that comes to mind is it seems like education would contribute to people's ability to like potentially the people that are more educated and probably wealthier may have access to wearables or technology, more higher end technology than people that are not. So that's one thought, and I'm interested in hearing Steve's perspective on that. But then connecting that to our project, or at least my personal research. So I do work in the space of diabetes, and a lot of the work I do currently leverages continuous glucose monitors, so which are wearable medical devices used by some people with diabetes. But there's definitely, for that particular device, it definitely introduces disparities because there's a cost associated with it. Oftentimes people that have better insurance or more access have higher access can afford these devices, and people that are lower income tend not to be able to afford it. But I think this applies to probably a good amount of mHealth research and just technology. High-end technology is costly. So I'm wondering how to leave the conversation without thinking about, well, there's no solution and we're just all here. But those are some thoughts I'm interested in.
So I'll start because I think they're great thoughts, and I could take up the rest of your day talking about them, because I think first they're very accurate. I think that I like what Vivek said at the beginning of that. mHealth technologies can and should be breaking down barriers and being kind of a key to addressing a lot of the inequity that's in healthcare. But because a lot of the work that's been done with wearable sensors the vast majority of it has been built around a kind of a bring your own device mindset. It's been limited to individuals, as you point out, who have higher educational status, who have higher socioeconomic status. And so in many ways, that kind of research, and I'm guilty of this, our group at Scripps, we did and are still doing what I think is a very exciting study in COVID around, but to be part of the study, you had to already own an Apple Watch or a Fitbit or a Garmin, some wearable sensor device. And so we've published, I think, 5 or 6 papers off of this, but have always had to just say we have a skewed patient population. But I think it's still early in wearable sensors. So when we started the digital medicine group at Scripps in 2013. At that time, a Fitbit was a waistband device that you had to plug into a USB to plug it into your computer to be able to see the data. All right, so it's still, very early, which it just means that we have to recognize that and then just change our thinking. And I think part of the change in thinking, and I realize I'm getting on a tangent that'll take me too long, so I'll try to not do that. But that a lot of what we do with digital health technology right now is built on kind of how do we add it on top of what we already do in healthcare. And so because we think of that way, we're not kind of addressing the what Vivek mentioned, how do we actually use this technology to be transformational? And in my mind, the way to do that is to really think about solutions, starting with what the digital technology allows, as opposed to how do we make this digital technology fit into how we currently do research or how we currently do care. And again, that's going into details of that, which I love doing, would be too long. So we just have to think differently. And now, as opposed to even 2 years ago, there's wearable sensors are getting better. More medical grade, able to do more. Some are like, there's an FDA cleared device that actually does cuffless blood pressure, stroke volume, cardiac output. It's amazing. And it costs $3,000 as a wrist wearable. You're not going to have, but you can also get when I think of it from a cardiology standpoint, that any of my patients who wants to get an EKG at any moment just can, those who have a smartwatch can reach over and touch the crown. I think the healthcare system should be buying all of my patients a watch that can do that, especially everybody who I see, who has palpitations or has some, concern. So I think the solution, I think everything you said is a problem, but it's a problem based on historical thinking that it's up to young, smart people like you and others in this group to say we have to think differently and outside of the way we normally think of using these technologies. And part of that is creating healthcare research that it provides the information, the technology needed, but critically, to me, one of the most ignored aspects of digital health technology of mHealth is the communications, the 24/7, the educational need, the aspects. So much of healthcare is built around, and healthcare research is built around episodes of care. You're going to do this and we'll see you in a month or we'll see you in 3 months and stuff. When you have 24/7 connectivity, if we give somebody a smartwatch who's chosen to not buy a smartwatch or an activity tracker, and we want to do that as part of a study, or let's say it's medical grade, and we do, part of that has to be the 24/7 availability of education and communication as we do that, So anyway, I apologize because I've given you a bunch of thoughts that stir around in my head a lot without a really clear answer, but the points you raise are real. They need to be addressed, and it just needs to be addressed in ways that typically have not been done in healthcare and healthcare research.
Let me just add something, because I think there are two sides. One is that of the designer. And if you know that going into the population that you're going to work with, that this is going to be a big disparity, the question is, can you design differently? So in our center, we did a project on uncontrolled diabetes in African-American women. I think it was over the age of 50 or something. We didn't use smartphones. We call them dumb phones. So we didn't use smartphones, but it was a lot more work for us. But what we did was leave the ability to be able to utilize something that would try and address the inequity. When you think about the issue of wearables, and Vivek and I had a meeting, for example, separately with the person, one of the health plans that we have for our faculty and staff. And I think eventually, it's just what Steve said. I would like to see the health plans provide these things. Everybody, it's kind of, I think it's kind of a little outdated that it's just the gym membership, particularly when you see Medicare Part B and all that, and they're offering, gym memberships. There is technology, I think, that could and should be offered that would, really be very good for this older population. So, I will hope that, Vivek and I are able to influence the health plan to be able to integrate technology much better for our faculty and staff. It's partially I sit on the UC-wide healthcare task force. So that's something that we will promote and push. So does that answer your question? Give you some ideas?
Yeah, it does. I have more questions, but that's
okay.
Maybe can I add to? I
just wanted to share.
Sorry, I know Caroline has it. Is it? I just want to add to that question. Is that okay, Caroline? Or yeah, yeah. I think what Steve said and what Vicki said are all great, and yeah, I think exactly. I think it's a wonderful question, Temi, and yeah, exactly. Thinking about this in that way is also opens the space of innovation too, right? So, like for example, how is like some things used for better health communication to improve maybe people's access, or coupling. I'm working with folks here at NYU Medical on a lot of telemedicine and remote patient monitoring efforts, and because in New York City there's a lot of healthcare champions, like community health workers, who help with programs that maybe how do we couple that with a technology to augment that function, which is known to be improving kind of those base factors for a lot of people too. So just wanted to add to some more examples of thinking about this in context. Thanks.
No,
I just wanted
to share. Oh, never mind.
No, you go ahead. Before I forget, because Tim brought up the personal health record, just for those who are interested, a really good example of one is a company called Picnic Health. It has a personal health record. So if you want to look at that. So I apologize.
Okay, Caroline, go ahead.
No, I just wanted to share really quickly. It's not so much of a question, but this is a topic I think about a lot because of most of my work is with Spanish speakers. And so my research, we provide everybody the devices that we use for this very reason. But one question that gets to sustainability, and I know that the ultimate goal might be for healthcare plan providers to provide some of these devices, but that's often, I think, a longer ways off than sometimes your immediate healthcare center. So we often think of the data we collect as pilot data for future grants. I've actually used some of my pilot data to request our hospital, so the medical center, to provide devices for specifically some of our clinics that serve a lot of people with inequities. Because my pilot data has shown that people will borrow the devices, use them, return them, which was one of the biggest concerns apparently the hospital had. And so the idea of integrating, I think, a lot of our research with actually what's happening on the ground in our clinics, we can use that data, I think, to support some of that. And I just wanted to encourage people to do that.
Great suggestion. I think that's kind of what you were hearing Rumi talk about, is like when you are out and about and if you can provide the data, you can sometimes convince people to integrate it. You have a question.
Hi, thank you so much for all the great talks and information. I'm in the same team of Tammy, so I think that we are working on the same project. So basically, the idea is that we're thinking about using CGM or continuous glucose monitor while providing that glucose information and using that opportunity for additional patient education to improve their self-management of diabetes. The population we are working with, the data has suggested that we are working with about 40% of African American, 40%, yeah, 30% about Hispanic population, and about 30% of non-Hispanic white. So in terms of, so my question is related to the generalizability of the intervention that we are developing. That what would be your suggestion on development of it? Intervention that could be generalizable across the three different, possibly very different population. And so what will be the pathway of the intervention development, and how do we, during the time of intervention implementation, how do we individualize them? What will be your suggestion? I think that's part of the social equity to me, that to make sure that people are getting what they need. So I thought that's appropriate to ask that question.
I have one comment. Sorry. Okay. Yeah, no, thank you for that example and question. I think it's very interesting. So yeah, oftentimes as scientists, or, we want to generate generalizable knowledge, or, on the computer science side, we always love generalizability. But I think it's a question like, you probably have this answer, but to learn more about like who would this be generalizable to, or should it be generalizable to, given, especially I gave a whole slides about incorporating context, and that's not always the same. So maybe one way to think forward on your question is like, what aspects should be generalizable or could be, right? And what parts should be specific to, sometimes we call them invariant and variant aspects on the analytical side, and unpacking that might be helpful to see where, how to adapt, and it's totally reasonable and kind of a systematic way about that transfer question.
Steve, any comment?
Yeah, I mean, because I think the question you asked to me is one of the most important questions to ask in any mHealth related intervention, because it's not about the technology, it's about the information that technology provides to the user. And then the biggest challenge for us as researchers is saying, okay, how do we provide that information back to the individual in a way that's valuable to them? And what makes that very hard is that it's going to be very different for some people. Something that some people find empowering. I want all my data. I want to see my CGM. I want to see this. To other people is very stressful and very it has a negative effect on them. And I think that this goes to too many projects kind of built in the past saying, well, if you have any questions, talk to your doctor, or if you have any questions, call the research assistant. And it kind of puts the burden on the research participant, as opposed to putting the burden on the researchers and saying that, okay, we have to go into this knowing we have to create value to the participant, in this case, in their CGM. And so one of the ways we're going to set up this trial, and I think this is what digital technology allows us to do that you couldn't do with paper-based things, is saying, you have to kind of go in and over time individualize how the return of information. So ask the question, every time saying, here's your 24 hours of data. Was this helpful? Did you find it interesting? Is there more information you want? And to look at it. Too much of research, too often we create this very linear process saying we have a protocol, we're going to implement the protocol, and then when the study's done, we'll look at it and see if we were successful. I think with digital technology, we can kind of embrace complexity science. And the idea that means that we're going to start with this, what we think is a good idea of a protocol, and this is what we think is best. And we've talked to participants, we have a good idea, and we're going to do this, but we're going to go into it saying we really have no idea what we're doing. And we're going to make sure that we're going to learn in real time. We're going to see how many people are using their CGM. We're going to see if somebody stops, and we're going to find out why. We're going to see, you know, as we return information, we're going to see what's valuable and what isn't valuable. That's really hard, and it's more complicated. It's a very different way to set up a study, but I think that's how you really take advantage of the technology to really change the way you do not only research, but doing the same thing in clinical care.
I'm going to give you an answer that is a very privileged answer, and it's privileged in the sense of my capacity to be able to get grants, because you need a little more time to do this. But I tend to be what's known as, at least we kind of call it that, a brick by brick researcher, which means I don't want to do all three groups at the same time. So I start with one that's the most difficult and has the worst problems, and get the design kind of worked out and understand what the issues are. I slide in the next group and then start doing the comparisons from that ethnic group to the next one. And then I bring in the third one. And it really allows me to see a lot of differences from everything from the recruitment to, you know, patient preferences. And so even though I have the same topic, it allows me to kind of specialize it for how to deliver it. Because, you know, the thing that I learned, and Vivek will know, Molly Coy, is that as researchers, we can do anything and come up with great science, but the ability to customize it to be put into the healthcare setting, it can't be super expensive. It has to align with, you know, patient engagement and patient preference things in order to make it, you know, have great uptake. So I've really started, like, if I were doing the grant, I'd send the grant in and say, year one, we do this, year two, we do this, year three, we do this. And then in year 4 and 5, we then do all these comparisons and stuff. So that's kind of how I've evolved. It takes more time, and it sometimes takes more resources, but I think I can end up by the end really putting it into a context where it's more usable, and where, you know, I haven't, you know, kind of helped nobody because everybody had something they wanted to do different. And it's kind of like, oh, well, you have to, it's like what Steve said, go ask somebody else because can't quite do that for you. So, but that's a very privileged answer, because it means I can get that many years of funding to do it. So that would be, you know, kind of my thoughts. We're going to get close to the end here, so I'm not sure if we have time for any additional questions, but you can put them in the chat and we will try and get you answers at some point in time, because I want to make sure we get you out of here at 10 so that you can have bio breaks and all that kind of stuff before you go to your 10:15. So what I'd like to do is to give Rumi the opportunity to make some last comments.
Okay, thank you, Vicki. And again, thanks for having me. It was actually, I thought, real good to hear all the questions. You guys are working on very like topical, and you know, there's no clear answers to the questions, but I think that's they're good. They'll be good exemplars for other work going down the road. So really happy to hear all those questions, and really look forward to seeing you know, how everything develops, and all the best to all of you.
Steve.
Yeah, I'm just excited to see all of you. I know this is a great training program, and just the fact that all of you have taken the time to participate in it, you're going to be much better prepared to lead this next generation of research and work that I really think is incredibly important in dealing with a lot of the shortcomings in healthcare, but in particular the inequities in healthcare. So I'm thank you, Vivek, for letting me be part of it. Vicki, thank you for doing a wonderful job of leading this. I wish we could all be doing it in person. And Rumi, thank you again for such a wonderful presentation.
Let me thank our host and our guest, and also to just congratulate the scholars in terms of taking the time for your schedule. As I can say, having been in those seats, it will make a difference in terms of your career. So I really appreciate it, and appreciate Vivek for making sure that we have some time, that you had some time to talk about social justice and fairness issues. So I'm going to throw it back to Vivek at this point.